Hey everybody, it's Dr. Wood, and today we're covering Chapter 14, the Parenteral routes of administration. So what we're talking about here is anything parenteral is going to be outside of the alimentary canal. So this is typically going to be things not given through the skin, through the GI tract. And so the big things we're talking about will be intradermal administration, subcutaneous, intramuscular, and then intravenous. So what are the advantages of using a parenteral administration? Well, basically, in some cases, you may need less of a dose. So you may find that some drugs have better absorption because you're putting it right into the bloodstream, essentially. So you may need less of it. Medications that cannot be absorbed via the oral route may have an easier time getting put into the parenteral route. Medications get into the system much more quickly. You're going to find they're directly in the bloodstream. They're going to be absorbed much more quickly. And then it could be good for patients who cannot tolerate things orally, and maybe there's not a rectal dosage form available. So this is where the parenteral route comes into play. Some disadvantages are, one, it can be painful, can be traumatic for some patients who are particularly needle phobic. There's always a possibility for infection, and then once administered, you kind of can't get the drug back. And so as opposed to, like, say, a topical drug you place on the skin, you can take that off pretty easily. Once the drug's in the bloodstream, that's it, you're done. And possibility of nerve and tissue damage, although this is rare, but it can depend on the medication you're giving. So some of the equipment you're going to need, you'll always need a syringe in order to administer one of these. You always want to use the smallest one necessary to get the needed dose of a medication. So if the dose of the medication, say 1.2 mLs, then use a 3 ml syringe, right? If it's 0.6 mLs, use a 1 ml syringe. Using things that are kind of too big can make it more difficult to give the medication slowly if that's how it needs to be administered. In terms of syringe tips, there's two varieties you're going to run into. This is what we call a plain tip or a slip tip. This is where basically the needle will be applied onto it and just friction is holding it in place. This is what we call a lure lock tip, and so this is where they actually have to screw on to the end of that. These are very particular connections to where you can't accidentally hook this up to something, say, via the oral route and things like that. So you'll find both of these used pretty commonly within the hospital setting. So the syringe itself, you'll find the barrel is going to be indicating the different demarcations here. We've talked about the calibrations and things like that. It's where they're actually holding the medication. And again, depending on the size of the syringe, you'll find that the calibrations will be a little bit different. So that's why you want to use the smallest one as you can, because you're more likely to get a very exact sort of dose there. It's important to make sure you don't touch here on the plunger, because that can contaminate the medication potentially as it kind of moves in. If you were to use that same syringe again, etc., you can find that contamination can occur. So, as I mentioned, the plunger is going to be the actual thing you put your thumb on to deliver the medication. Don't only touch the end of it, not the actual inside of it. And that plunger does form that tight seal inside of the barrel itself. That keeps the medication from leaking out, essentially. Now, needles, this is important because the choice that you are going to pick is dependent on how deep the needle needs to go, the viscosity of the medication, the safety features of it, and then also patient comfort is going to be a concern here. So when looking at the different dimensions of it, you're going to see the length can be important in terms of like how far down the medication needs to be administered. The outside diameter, which we'll talk about a little bit later, how thick the wall of the needle is, and then the actual point itself. So you're going to find that some things are better for, say, for instance, intradermal administration, short bevels, regular bevels. That's basically what we're talking about here, is that kind of the slope there, or how sharp of a slope you're going to find on the actual tips of the needle itself. Okay, the inside of it's called the lumen. If you ever see that, the bevels is going to be this edge here, and then this is the shaft of it. The hub is what actually gets connected onto the syringe. This is an example of a slip tip needle where it would just be placed on there and kind of held in place by friction. So when we say needle gauges, this is referring to sort of how thick the needle is, and so it can range anywhere from 14 to 31 gauge. And just note here, it's a little counterintuitive, but the higher the number, the smaller the gauge is here. So for instance, when you hear, say, someone says get 2 large bore IVs, they're typically talking about something like a 16 or an 18 gauge, versus if you're using a very small amount of medication, or say something very, very tiny, it'd be, say, something like a 28 gauge, 31 gauge, etc. You tend to find that the smaller gauges are good for, say, subcutaneous injection. So think like insulin or heparin, patients that may be giving the drugs themselves. These tend to be less painful, obviously, because they're much smaller. The large gauges tend to be for more, say, like viscous medications or things going into the muscle, IV potentially. Obviously, the larger the gauge, the more flow you can get through it. So when someone gets a large bore IV intravenous, that usually means they want to get a lot of like things like fluid and medications through very quickly. So general rules when using injections, make sure you use disposable needles and syringes to prevent cross-contamination. Obviously, every time you use it on a different patient, just get rid of it and use a brand new one. Make sure to use aseptic technique, which means you're keeping everything as sterile as possible. You never ever touch the needle. You never touch the barrel of the syringe except for the very end of it, or the plunger, I should say. You make sure you're, using alcohol swabs on the patient effectively, all those sort of things there, right? Never ever swab off the needle shaft. Always get a new one if you're not sure if it's sterile. Always err on the side of sterility here, okay? And then we'll talk about using filter needles in a second when using glass ampules. Now, in general, you never ever combine two medications in the same syringe unless you have a really good reason to, so just never do it for the most part. And then basically when you have a medication that you're drawing up, place it next to the container, the syringe next to the container, so that way you can see, okay, this is the medication that I drew up out of this container. I know this syringe is that drug essentially. And then when you're applying the medication itself or doing the injection, make sure the area is free from restrictive clothing, trauma, anything like that to help it make sure it gets into the gets absorbed effectively. Now, again, other rules, make sure you're using the correct technique, which we'll talk about a little bit later on here, and let the patient know, hey, it could be pretty discomfortable, or it may not be very comfortable for you. Depends on the route, site, etc. If you need help with kids, sometimes you have to get the parents to help out with that, to hold them down. Just depends on the case. And then make sure to explain the injections to the parents as well, since they may be pretty apprehensive about the whole thing, right? And again, never use injections as a disciplinary threat. You never want to do that. They should only be used if absolutely necessary. You don't want to tell a patient, hey, take your medications orally, otherwise I have to give you an injection. That's not really good medicine, not very ethical. So ampules tend to be a single-dose glass sealed container. Here's an example here of a ampule. Notice here is sort of the glass end. We'll talk about how to use those in just a moment here. You'll find the glass or plastic containers, B and C here. These are typically going to have metal enclosed rubber seals on the top here. Basically, you flip off the lid and there'll be a little rubber grommet you'd be drawing up medications through. And then you can have things like pre-filled syringes, which are typically going to be single dose and then they'd be disposed of afterwards. So using an ampule, you'll find that it's important to make sure to use alcohol to go ahead and swab off all this to make sure it's clean. And then you'll tap off the top to make sure any liquid in here goes down to the bottom. Next, you'll take a piece of gauze or something to prevent yourself from getting cut. And basically that little neck there is designed to break when applied some pressure. So you basically hold the bottom, grab the top, and then just basically snap it in half essentially. When you do that, it's going to help to, you'll now be open, you get the medication out of it. It's important to make sure to discard both of these pieces in the sharps container because you don't want anyone else getting cut with that. Now when you're doing this, go ahead and apply or put the needle into the ampule, and then you'll use a filter needle. Basically, this is a needle that has a filter on it to prevent any shards of glass from getting into the syringe. You then draw that up, the amount needed. You would then cap that needle, dispose of it, and then get a brand new needle in order to make sure that you don't put that glass back into the patient. Okay, so that's an important thing there. You want to make sure you go and switch those out upon filtering. Now, if you're using, say, a vial like this, you're going to know that you just basically have to pop off the top here. Here's an example one without the top on it. And there's a little bit of rubber grommet right in there. And this is what you'd actually put the needle straight through in order to drop the medication there. It's important to make sure you swab off this with alcohol beforehand, like an isopropyl swab. And that way that is clean, and you can put the needle through, get the medication you need, and then you're good to go. Basically, you'll remove the needle cover. One thing to note here before you actually put the needle into the vial is you want to draw up air into the syringe equal to the amount of liquid to be withdrawn. So if you need to drop 3 mLs of liquid, you want to draw that syringe up to the 3 mLs of air and then apply it in there. The reason for that is you want to equalize the pressure between the air and the liquid here. Otherwise, if you try to draw out, say this is set at 0, you put that into the vial and you try to draw it out, that creates a vacuum, and then the plunger will just go right back down. So to prevent that, you go ahead and draw up the syringe with air up to the right amount of what you need to withdraw from the vial, place that into the vial, and then you can draw the medication. Okay. So once the air is injected into the vial, then you'll kind of release off the plunger, and that will allow the medication to fill in, and then you get to the right amount and then withdraw that needle from the vial. So once the medication is actually drawn up into the syringe, you want to make sure you're placing the syringe sort of facing up, where the barrel is going to be basically pointing straight up, and you're going to be able to flick it with your finger in order to make sure any air bubbles get up to the top of the syringe there. At that point, you can then draw the plunger back and then allow any air to stay at the top, and then you can expel any remaining air. The main point here is you don't want to inject air bubbles into your patients, because that can cause an embolus and be very dangerous. So you want to make sure you get the right dose and get rid of all that extra air that's in there. Okay. Now, if you ever have extra medication and you're using a multi-dose vial, meaning it has preservatives in it that keep it sterile for a while, you don't want to put medication back into there because it's contaminated at that point. Now, sometimes you have medications that come in a powder form. It's called lyophilized powder or freeze-dried powder. And basically, you have to put that into solution before you can actually draw it out and give it to a patient. So we call that reconstitution. And what you use to reconstitute is called a diluent. This may either be sterile water or it may be saline, sodium chloride. That's called reconstitution. And basically, what you're going to do is draw up a amount of diluent that you need, and it will be kind of explicit based on the vial and the drug that you're using there. Basically, the package instructions will tell you how to do that. But you're going to take the right amount of diluent from the vial, and then you'll then put that into the actual vial itself. That will then mix, and it will allow for the medication to go back into solution. You could probably, I wouldn't shake it, because that can cause some issues with certain medications, but kind of gently swirl it, and then that will allow it to go into solution. And once you notice that there's no particles, there's nothing else like that, then you can go ahead and draw out the medication like you would normally. So as I mentioned, go ahead and mix the powder into the diluent. And if the vial is multi-dose, so it means you can get multiple uses out of it, you want to make sure to mark off all the times, the dates, etc. Make sure you initial it so that way people can go back and know who did it, and store it according to label instructions. It might need to go in the fridge, may need to be at room temperature. It's going to be very drug dependent. So when injecting medications, you want to use the smallest gauge and the shortest needle length possible, depending on the use here. You're going to find that you want to change the needles if the liquid coats the needle during preparation. So, and again, usually you're going to be using a larger needle to draw out the dose. You'll then switch it out for something like smaller gauge. And then we're going to position the injection site to reduce muscle tension. So I'll kind of show you some examples of that in a little bit. And then try to avoid any sites that are problematic. And then if you can, try to distract the patient. Sometimes that can help them if they're particularly needle phobic. You'll then insert the needle into the tissue smoothly and quickly. Again, you want to hesitate on there because then the patient might kind of freak out when you do that. And then hold the syringe steady while in the tissue. Inject the medication slowly and smoothly, depending on how long it needs to go over, sometimes a few minutes, sometimes a few seconds. And then go ahead and withdraw the needle at the same angle of insertion. And make sure to use that aseptic technique to keep everything sterile. So you've swabbed off the patient beforehand with alcohol, inject it, and then pull it out. Make sure once you're done with withdrawing the needle from the tissue, then you want to go ahead and apply gentle pressure, usually with a piece of gauze or something afterwards, because it may have some oozing or bleeding. And then make sure to rotate injection sites. So you don't want to use the same site over and over again, because you'll find that some scar tissue will develop there, and injecting may be more difficult or more painful for the patient. So some examples of how the angle of attack can be important for the type of administration. So for instance, with intramuscular, it basically is a 90-degree insertion to the muscle. For, say, subcutaneous, it's going to be more of a 45. And then for intradermal, it tends to be at around a 15-degree angle there. Because again, where do you actually want the needle to end up when administering it? Do you want it subcutaneous? Do you want it in the skin? Do you want it in the muscle? So typically for intradermal injections, you're going to be using this for very small amounts of fluid. Typically, you're going to be using those tuberculin syringes or potentially for allergen testing, things like that. You want to use a very short needle because, again, it doesn't have to go very far into the skin. You can use a very fine gauge, like 25 to 28 or so, and then use that intradermal bevel. Typically, this is for volumes of less than, say, 0.1 ml, maybe less, okay? Some sites where you'd actually want to administer this, you can either do it on the forearms, you can do it in the upper back, etc. These are the most common intradermal sites of injection. Usually for like allergen testing, you'll typically see people with a ton of injections on the back, and that's where they can look to see for each individual allergen what the patient actually has a reaction to. So when giving drugs via the intradermal route, make sure to prepare the medication according to the order, locate which injection site you're going to use, and then clean off the area with an alcohol pad. You'll let it kind of dry off, which alcohol typically dries pretty quickly. And then you can stretch the skin tight with your non-dominant thumb and index finger. So if you're right-handed, go ahead and use your left hand to hold that skin tight. And then with the bevel facing up, then you can go ahead and place the medication, again, around a 15 angle degree of attack or so, and insert that into the outermost skin layer to make sure you're not going much deeper than that, because then you have now a subcutaneous injection. So you want to stay pretty shallow for the most part. And then you'll slowly inject the medication until you see a little wheel forming on the skin there. So you'll see like a little, some people call that a bleb, but you'll see like a little tiny wheel form of the medication actually underneath the skin. And so then you're going to withdraw the needle. You'll wipe the skin with an alcohol swab, maybe apply some gentle pressure afterwards. You may have a little bit of bleeding there, but do not massage the area. Don't apply very hard pressure. And then once you're done, discard the syringe and needle into the sharps container. So look at that wheel here. You can see it forming. This would be something like a PPD or a TB test, and you can see how this would look like in the picture here. So again, right in the epidermis, or actually in the dermis itself, and you're going to see that little wheel. Patients may feel concerned that that's there, but that will go with time. As the drug gets absorbed, you're going to find that will dissipate pretty quickly. Now, giving drugs subcutaneously, this is going to be a very similar sort of action here, except you can give larger volumes typically, but this will be applied the needle directly into the adipose tissue here. It's going to be a little bit slower absorption, not as quickly as with IV or intramuscular, but good for smaller doses, maybe just a few mLs. It's good for more kind of non-viscous, non-irritating sort of drugs here. So some sites, typically the abdomen is used very commonly, mainly if patients are applying this themselves, but certainly you can use some other sites as well, right? Maybe the around the triceps area, the anterolateral aspects of the thigh, things like that. Just depends on who's administering the medication. If it's themselves, typically the abdomen is the most common. And again, you want to follow your typical guidelines for doing this by using higher gauge needles, say 25 to 31, so pretty fine gauge here. And then typically 2 mLs is a max. You may see a little bit more in some cases, but 2 mLs is a pretty good rule of thumb. And as I mentioned, rotate injection sites. These are going to be things that patients may be administering multiple times a day, like insulin or heparin, and so you want to make sure you don't use the same site over and over again. Okay. Then again, typical needle length does not need to be very long. You may see like a 1/2 inch needle being used, something like that, and insert more at a 45-degree angle versus say like a 15-degree with the intradermal. Again, you're going to be preparing the medication order, as been prescribed. You'll locate your site. You'll swab the area with alcohol, very similar to the intradermal, and then again grasp that skin firmly with a non-dominant hand. See here was going to be given to the upper arm. And so you'll pinch the subcutaneous tissue between the thumb and the finger. So instead of like stretching it out like you would with the intradermal injection, you're going to kind of pinch that together. You'll insert the needle at roughly a 45-degree angle, then release the skin, and then you'll pull back on the plunger. People do this to make sure they don't pull back blood, because you may be in a vein at that point. And then you'll slowly and steadily inject the medication into the subcutaneous layer. So you'll then withdraw the needle at that same angle. You apply pressure with an alcohol wipe, and then you can gently massage if it's appropriate, but generally you don't need to. And just make sure to follow any safety guidelines according to discarding any kind of needles and things like that. Next up, we're going to be giving medications intramuscularly. The nice benefits here is it has pretty rapid absorption, better for more viscous, irritating medications. And in order to get to the intramuscular site, you're going to need longer needles and typically lower gauges here. And again, notice you're going to go straight in at a 90-degree angle. Some other things to consider though, like think about age, the weight of the patient. Sometimes you need longer needles if there's a high amount of adipose tissue. If the very young patients, they may have not very good muscle function, and so you may find impaired absorption. A lot of different things that may come into play here, and we'll learn those on a kind of case-by-case basis. Sometimes what you'll do for intramuscular medications, especially if you want to make sure that maybe a staining or an irritating medication kind of stays within the muscle, is what we call the Z-track technique, where basically here's the natural orientation of the tissue. By using your fingers, you can pull the tissue kind of to one side. By applying the needle down in the 90-degree angle, you'll then allow for that medication to be put into the muscle, and then when you release that finger, you'll find the tissue will then reorient itself, and then now it has a harder time getting back out because that needle track has now shifted. Unless the medication is harder to get out, it's going to stay right there in the muscle. Typical sites for intramuscular injections include the deltoids, the dorsogluteal site, ventral gluteal, things like that, vastus lateralis occasionally, or rectus femoris. Those are kind of the most common places you're going to be injecting this. Imagine if you're giving yourself like an intramuscular, say, EpiPen injection or something. A patient's giving it themselves. Usually the vastus lateralis is the most common use in those cases. So you prepare the medication just to the physician's order. You'll locate your proper site. Usually if you're giving it to the patient, then you maybe use the deltoid, and then you'll make sure to choose a needle of appropriate length. This may be dependent on the muscle you're using, maybe dependent on the adipose tissue, or how much they have the patient there, and then position the patient correctly to make sure you can get to that site. Typically make sure there's no clothing in the way here, and then cleanse the site with alcohol, just like we have before. You then hold the skin taut for, say, dorsal gluteal or ventral gluteal. However, for something like the vastus lateralis or, say, the deltoid, then you go ahead and pinch the skin. They kind of use what we call like a C shape. It's kind of a C shape like this to kind of pinch it together. And then holding the syringe sort of like a dart, just go straight in at a 90-degree angle, and then you can apply your medication. Make sure that you pull back that plunger there, make sure no blood appears in the syringe to make sure you're not in an IV site, and if there's no blood, then you go ahead and inject the medication slowly and smoothly. Then withdraw the needle at the same angle of insertion, apply pressure with the alcohol swab, and then you can massage the site if it's appropriate for 1 to 2 minutes or so, and then discard your stuff into the sharps container. So just as a summary, kind of your different sites of administration, kind of the most common ones are intramuscular, subcutaneous, and intradermal. Kind of review this note here that the larger size needles are the smaller gauges, right? Or should I say the lower gauges are going to be for more intramuscular. Usually you're going to be using the higher gauges or smaller needles for intradermal and subcutaneous. And then note how the length of the needle can depend on where you're actually injecting it. The longest being the intramuscular route, okay? Also note things like the size syringe you'll be using, note the injection angle, all those sorts of things. These are the things I kind of want you to take away from this lecture here, okay? If you have any questions, let me know, and I'll talk to you soon. Thanks.